Right, welcome all. I think we had 27 people waiting in the waiting room ready to come in, and we're up to 29 already. So thank you for joining us for a very exciting BSLM webinar, which is focused on children and young people. And we've got two fantastic speakers lined up for today. I'm Seb Gray. I'm a paediatrician in Salisbury. I'm the co-chair of the Paediatrics Specialist Interest Group. So if you're interested in children and young people and want to join that group, please do have a look at the website and sign up. We're in our infancy, pardon the pun, and we're not quite as progressed as Dan, who's our first speaker, who is the chair of the school specialist interest group. So lots of overlap. There's lots of people in the same groups keen to collaborate and work together. So Dan will be speaking first about embedding lifestyle medicines in school, and I'll introduce him first. Dan's background is mainly in education, but after completing a degree in sports science at Birmingham University, he spent a couple of years traveling the world and then set up an organic bakery and veg box delivery service. Exactly the type of friend you want to have. And that was 25 years ago, so way ahead of the time. Didn't really take off then, but I'm sure he's just the trendsetter like lots of things. He then worked as a personal trainer and nutritional advisor at a gym before training to become a PE teacher. And he was the head of PE for over 20 years. Took on roles about developing wider health and environmental projects, as well as roles coaching and developing new and existing staff. Over the past 5 years, he's joined the BSLM, completed the core accreditation, which I'm sure lots of you have done or are doing, and started a new programme across the Xavier Catholic Church Trust called Lifestyle First. This programme supports schools to adopt a health first approach, focusing on health promotion using lifestyle medicine and health coaching. He's written a UK IHCA accredited course to support other health coaches to work effectively in a school environment. Dan's passionate about developing an awareness of how our modern culture is creating many of the health problems our young peoples are experiencing. He also leads the School SIG, which I've mentioned, and is running a campaign to encourage BSLM members to speak at their local schools. And I know that he's inspired lots of people to do that and is collaborating with them by creating BSLM Lifestyle Medicine PSHE curriculum for these schools. He's a full member of the UK IHCA and on their professional register, involved with the setup of an alternative provision school and founder of his own company, Lifestyle First. Please do say hello in the chat to let us know who you are. And if you have any questions as the speakers are talking, please do pop them in. So over to you, Dan. I'll turn my mic off once we've seen your slides, and then it's all yours.
Okay, just...
So we can see your slides, Dan, so it's all yours.
Brilliant, thank you. Thank you, Seb. Really appreciate the intro there, and yeah, it's been great to be part of the BSLM and obviously be involved with the leading on the school SIG. I think it's great to feel like there's a real ambition to get into schools amongst our members, and hopefully I'm going to be able to give you a few pointers and maybe some resources and things that might be able to help you have the confidence and kind of yeah, get the motivation to get in and support local schools. So see, now my clicker's not working, is it? I'll okay, brilliant. Sorry. So my aim today is to hopefully give you a snapshot of what difficulties schools are facing, explain how lifestyle medicine can help to address some of these, and then give some examples of the work that the BSLM members from our special interest group have been doing and getting into schools, and share some resources and some ideas that you might be able to use if you want to go into schools, or encourage your school to get more involved from a lifestyle medicine approach. So this is kind of, sort of a national kind of summary, I guess, of what's happening in schools. We're seeing attendance levels dropping. We're seeing students less resilient, less able to focus and concentrate. Standards of behaviour are dropping. And this is, sort of not just in isolated little pockets. This is kind of something that we're noticing happening across, pretty much most schools in the country. And there's increasing levels of anxiety and special educational needs, and we're finding in schools that it's becoming unsustainable. The amount of time that staff are spending firefighting, the amount of interventions that are in place is going up each year, and obviously the funding just isn't really there to be able to deal with that. So we need a different approach. We need to find a way of getting in ahead of the game, preventative approach, obviously while still supporting those students that need support. So how can lifestyle medicine help? Well, this is something that I've been doing now for 3 or 4 years as my main kind of role, using lifestyle medicine, using health coaching to try and change culture in schools and actually bring sort of a different approach. And that approach is essentially making health the most important thing. That's what we're trying to do. And if we can take care of that, I know I've probably, if you've seen my presentations before, this is how I always start my presentations. It's understanding that if we take care of health, then everything else, downstream of that takes care of itself, and we get students that are much better focused, they're much more resilient, they're much more able to behave in the way that we know is going to help them learn and become the kind of adults that we want them to go on and become. And this doesn't just apply to the children, this applies to the staff, and it applies to the families as well. And so I think we're distracted a lot in our society, and bringing it back to actually, are these behaviors serving me? What are my values? Can we start to align that around getting myself into really good health? So just a question for you, a little bit of interactivity. If you were in charge of a school, what would you do to improve well-being? We're obviously looking for ideas all the time, and if you've got any bright ideas on what's needed, please share that either in the chat or potentially send it through to info@lifestylefirst.org, and we'll be really happy to hear from you. What we have created in terms of changing culture is kind of like, we feel that it's like anything, the more touch points you can have in the school, the more you're likely to get, sort of a shift. And so we are using health coaching for the staff, for the students, and for the families. We try and really embed it with the staff at the start if we can, because obviously that then has a massive impact throughout the school if you really get the staff on board and role modeling to the students with that kind of integrity, how to look after themselves and take care of themselves. We've also created, at the moment, it's a primary curriculum, which is based on the 6 pillars of lifestyle medicine. It also meets the PSHE criteria, so it can be used in that time slot for schools. And again, that's really bringing in all this amazing science that we've got now around lifestyle medicine and the impact that it can have on behavior and the impact it can have on, sort of energy level, focus, health in general. And then we're also now developing links between primary care networks and schools, because I think we're trying to get a funding model that it actually works across these two sectors. But what we're talking about here is in schools' interest, it's in NHS interest, and so to actually find a way that we can collaborate and bring that if you think about an NHS 10-year plan and getting into neighbourhoods, and really bringing that care into the community, this is something we believe is the future for how we can support schools better. So what we've been doing is designing courses, writing courses, and delivering courses for school staff. So if you have any schools that you think might be interested, and some of their staff might be really interested in developing, more health coaching and lifestyle medicine approach, we have a course that could be good for them. And we also do courses for existing health coaches who would like to kind of get the skills and confidence to go in and work in a school environment, working with young people, working with families. And so this is a course that we also offer if you know of coaches or are a coach yourself that would like to take on that role. So in terms of the BSLM Schools SIG, we'd love you to all join. It's a great group, and obviously we meet sort of maybe every couple of months, and share ideas and share, sort of examples of what work has been going on and what's been going well. And so I'm going to share a few of those with you today. What's great is we're getting the sleep resource which we created. So probably a couple of years ago now, one of the first things we did was create a sleep resource for the for BSLM members. So that's available on the BSLM website. You can access that, and it's got a presentation for the students and for the parents. It's got a letter that you can approach the school with. So it's a great resource, and it's all there ready, waiting to be used. And we've got members that are going in and delivering this. Nikki in the New Forest got together with 3 other GPs and a paediatrician, advertised to all the local schools, and they were doing a talk on sleep. She found it actually really enjoyable, and did quite a bit of a deep dive on sleep herself and found out lots of extra information, which she found quite good for her own development, and it was something that she could bring into her practice, but also really enjoyed then giving the talk, and found that the parents were really interested, asking some great questions, and is definitely keen to do another one. We've had many members delivering the sessions to students, Key Stage 1 and Key Stage 2. Like I say, the resource is all there ready to go. So I think that gives them a lot of confidence that they've got something that works, and we know it works, and we know the students engage with it. And even some students, I know Virginia did a model using balloons representing adenosine molecules and balloons for caffeine molecules, and kind of showed the competition for receptor sites. So she really went to town, and obviously that practical element is a risk if you're not used to teaching and working with children. But she said it went brilliantly. She's been doing it a couple of years now, so it's fantastic to see her get confidence and really pull that off. We have Sarah, who takes a different group from her primary school down to an allotment which the school have as part of their facilities. And so they work on obviously growing different types of fruit and vegetables, really helping the students to get an understanding of kind of how nature connects and the kind of connection to food. And the great thing is she's also then they've actually been able to bring that back to school and work with the school canteen and the chef there to include it in the meals and the school meals and the school dinners. So that's I think an absolutely fantastic project that's been going on. And then we've got many of you also that have been really sort of trying to get into schools, trying to talk to members of SLT, the chefs, the canteen staff, and the catering companies, trying to lobby for a bit of change in terms of how much ultra processed food is being offered, obviously reducing levels of sugar, and so again, just it really helps to be part of the group, because again, there's lots of different sort of ways in which you might reach people, different techniques, where I think if you're going to lobby for change with the canteen and with the SLT, it needs to be joined up so that you're actually running some programs for the students and for the parents to educate them, bring their awareness to why we're bringing in these types of foods, so that the canteen aren't losing money and there's not food going to waste, because nobody's eating the healthier stuff that we're putting on the menu. So I think there needs to be a joined up approach there, but obviously that's something else which has been happening. We've had Kate, who's working for Wellbeing Windsor, so like a charity that are kind of creating resources largely around mental health, but Kate's bringing in the lifestyle medicine element to it, and trying to bring some of those other pillars to that. And these resources are then being used in schools and being used with parents, and also setting up, it's called, can I remember? It's a parent space, I think. They call it Parent Space, where they are having a venue where parents can come to and just talk and get support and be given information and, you know, given hopefully some awareness around some really good strategies that can support them in parenting well and parenting effectively. And then we've also had Deepak, who's been into a school at a careers fair, talking to hundreds of parents and really sort of promoting this idea of lifestyle medicine as a career that might be something that these children could go on and aspire to be working in. So you can see lots of variety here, and you know, there's lots of other examples that I could have given, but this gives you a general gist and some of the, you know, opportunities that are out there. If you're interested in going into your local schools, lots of you may have children at schools. It's a great way in to begin with, but obviously having a contact with a school, knowing the head teacher, having a friend that's a teacher in a school, all of these are good ways in to obviously make contact and hopefully be able to go in and make a difference to these young people. So one of the things that we're going to do for the BSLM members is give you access to it's a kind of a BSLM version of our curriculum. And so there'll be a presentation on minimizing harm, presentation on sleep, and a presentation on healthy eating, as well as an introduction to lifestyle medicine presentation. So if you're interested in getting that, then please do again send an email to info@lifestylefirst.org, and within the next week or so we will send you the login details, and it will just mean that you can then access these resources, go into your schools, you know, with confidence, with some lovely looking, really fun resources that we know the kids love. And there's plenty there for you to obviously do a series of presentations, but we've tried to structure it so that you've got, you know, sort of at least an hour presentation on each of those topics. And obviously, like I say, you don't have to deliver all of it. You can sort of tailor it to the time that you have. The other thing which I mentioned at the beginning, and it's something that if there are members that would like to get involved or think there might be an opportunity in your area, we're trying to build this connection between primary schools and primary care. And if you feel that, you know, you have an opportunity and you think that potentially your area might be interested in kind of running a pilot, and there might be some funding available that we could use for that, then we would love to hear from you. We will provide resources, and we can train and place the health coaches, or you know, make this work for the local area, for the local schools. And so yeah, anything that you have, anyone who has any would like to find out more information, again, please reach out to us. That'd be great to hear from you. So top tips from the school SIG, those that have been in schools and been doing presentations. First one was, they wanted us to say that we all have a voice. And I think, you know, one of the things that we're finding obviously is that we can make a difference. Like, and you as you know, healthcare providers, GPs, you know, you're really well respected across school communities. And when you come in and deliver a talk, that voice is really has a lot of weight and has a lot of impact to these young people and to the school staff as well. So if you're able to get in there and start spreading this message, it really does make a big difference, and it's so needed. You know, you can have impact on huge numbers of people, and yes, it's, you know, will be really well received, because it's a message that schools are really craving. Share the basics. Again, we sort of think, oh, we're delivering a talk, it's got to be something, you know, really special, really unusual, really, you know, give all the nuances and the real, you know, detail. But actually, so many parents and students, they just need the fundamentals, and they need to be reminded of those fundamentals in a fun way, in a way that makes sense to them, and sharing tips and strategies to kind of start to nudge them into those behaviors. So it's the basics that we need to get right. You know, all the bit around the edges, they're great, and obviously there's some fantastic science around all of that as well. But really, don't be afraid to share the basics, you know, around getting good sleep and managing screen time and eating, sort of real food rather than ultra processed food. I mean, that's going to have a huge impact if you guys can go in there and get that message across. And the other feedback is it's actually really fun. Like, people that have gone in have like come out of it, buzzing and kind of like, oh, that was actually really good, and they feel like they've had an impact and made a difference to these young people. So yeah, the final point is set a date, because we've also got plenty of members who've been wanting to do it and they kind of say, I'm going to do it. And, it just, for whatever reason, we're all, they're so busy. So it's always, unless you've got a date booked in where you've actually, set it in the diary, committed to it, that's going to happen. But so that's the advice that the members have said, to give to you guys. So thank you so much for listening today. And obviously, like I said, there'll be some questions, I think, at the end. But yeah, any information you need on anything that I've mentioned, the email address is at the bottom there, and I'll look forward to hearing from you. Thank you.
That was fantastic, Dan. Thank you so much. I always love hearing you talk. There are no formal questions yet in the Q&A, but I've got one, if that's all right. And it's one I think that's been discussed before, and that's about health inequalities. So there is still this opinion that lifestyle medicine is something that's only really for those who can afford it and those who are affluent. So doing lifestyle medicine approaches through schools, I think, is an absolutely fantastic opportunity. The areas that you mentioned, like the New Forest, Windsor, I know the New Forest team, and I know it's a very affluent area, it's a very affluent school, and I've done work with schools before where you let everyone sort of sign up to it, but the schools who have taken on board, who've had the resource, time, and the people interested, have been those from the more affluent areas or even private schools. So how do you make this lifestyle first approach accessible to those living in more deprived areas than those that need it the most?
It's a great question, and I think it is a challenge. Absolutely, it's not straightforward. But what we're trying to do is our curriculum meets all the PSHE criteria as well. So it's a straight swap for a PSHE curriculum, and it's also really affordable. We've kind of really made sure that we're pricing it at a point that's not going to put schools off sort of getting involved. They were very comparable to existing PSHE curriculums out there, and it offers an awful lot more. It's got a parent portal and a staff portal as well. So we hope that it offers really good value for money. And I think there is in these schools, there is obviously a great need to support children from a lifestyle medicine perspective. And I think the key for us is to really get in front of those school leaders and get into places where we can start talking at conferences and actually start to bring their awareness to this approach. Because like I say, a lot of these schools are firefighting all the time. They're struggling, the parents are struggling, and if we can just bring, like you say, that education to the school community, well, all of a sudden you gain a bit of momentum, and what's like when something starts to take hold in a school community, it spreads really quickly, and so I think that's our target, is to try and really see if we can replace existing PSHE with a lifestyle medicine PSHE and build in the health coaching and stuff around that.
Brilliant, thanks. So the questions are coming in now. I've got one on the Q&A part. I'll come to the chat in a second. So this from Sanjay Suri, who's a retired paediatrician. Thanks for that insightful talk. Any initiatives to address preventive mental health using meditation, breathwork, or yoga?
Absolutely, yeah. As part of our curriculum, we have a breathwork tool. So it's a series of lessons where each week there's a 5-minute tutorial, so they can engage with that. And then they can revisit at any time. So during the day, if they want to, if the children have got a test coming up and they want to kind of get them into a focused mode, they can go into doing some breath work to help with focus or calming down, or the tool is there. And we haven't got yoga as part of it, but we have got somatics. So we've got some a program which is all around kind of just building that body awareness. It's a practical element to it, so it will be delivered either in a PE lesson, and it's really helping to kind of sit alongside the breath work and the meditation element, so that you're really building that connection back into their bodies.
Brilliant. There's one more that's popped into the Q&A from Divya Goridut, who's a paediatrician as well. So thank you, Dan. I joined in late. Do you work with secondary care too? Any resources for general paediatricians you have will be immensely helpful. They are immensely helpful. But over to you, Dan.
Yeah, so as a BSLM member, you can have access to the resources which I've just mentioned. Obviously, they're designed to go into schools, but they can be used just as easily with other situations and other scenarios that you might work in. Really, they're just really nice tools to kind of help get onto a primary school level some of the concepts of lifestyle medicine, and they're fun, and they build in kind of animals and superheroes, and so hopefully it's something that makes your job easier, and the children are going to kind of engage with it and then be more receptive perhaps to adopting some of those behaviours.
Brilliant. And I know Maria hasn't popped it in the Q&A, but it's asking for tips. So I've tried to get into schools in London, but they seem to have too little time. Tips to get in.
Great question. I think it's timing it with maybe like a Healthy Schools Week, or if the school has some kind of event or mental health week, or those are the good times, because they often are looking for different ideas, different options to make those weeks fun. The other thing is just to maybe contact the PSHE coordinator. I think if you try and contact the head teachers, they're so busy, you probably won't get a response. But if you contact someone, maybe like the PSHE lead or the mental health lead, they, I'm sure, will be really pleased to hear from you, and would welcome you to come in and do some kind of assembly or some kind of PSHE lesson for them.
Another way is to become a governor as well. I think schools are desperate for more governors. Anyone who's part of a paediatric interest group or schools interest group is going to be welcomed with open arms, I think. And Monica's posted that she's had some limited success with local nursery, which is great to hear. So great to hear. Dan, thank you so much. Like I said, there may be more questions that pop up in the chat. If you could, either chat or the Q&A, if you can keep an eye on that, that would be fantastic. There's none at the moment outstanding, but yeah, if you could keep an eye, that would be fantastic. But thank you once again for another great talk. And for anyone interested in joining the School Specialist Interest Group, please get in touch with Dan directly. Is that all right? Or via BSLM office? Because hopefully you want to join both SIGs, which we would strongly encourage, because there is lots of cross-contamination and working together, which is great to see.
Thank you, sir.
Thanks, Dan. Which brings us to our next speaker. So Dr. Richa Agnilhotri, who is joining us in between shifts. Hopefully her face will appear in a second. She's working in Canada at the moment. So Dr. Richa Agnilhotri is a consultant community paediatrician, mum of two, based in Niagara region in Canada, where she's passionate advocate for the health and well-being of children and youth. She completed her medical education in the UK and then abandoned us. So residency in general paediatrics at Western University. Currently holds the position of assistant clinical professor adjunct at McMaster University, and serves as the past president of the community paediatric section of the Canadian Paediatric Society. Additionally, she's a board member of the Paediatricians of Ontario section of the Ontario Medical Association. She's involved in working with several specialised committees, including the Early Years Task Force, the Anti-Racism MedEd Working Group, and the Sleep Special Interest Group of the Canadian Paediatric Society. With a focused interest in child development, behaviour and mental health, she's pursued advanced training in paediatric mental health, particularly in the diagnosis and management of ADHD, autism, anxiety, depression and trauma. She's trained in CBT for anxiety and continues to expand her expertise to meet the evolving needs of the community she serves. She's deeply committed to upstream prevention in healthcare, recognising the profound impacts that early intervention and proactive strategies can have on long-term health conditions. She's certified in plant-based nutrition and healthcare coaching, and is also board certified in lifestyle medicine. She integrates evidence-based lifestyle strategies into her practice, working collaboratively with children and families to develop comprehensive care plans that support physical, mental, and emotional well-being. I've seen her speak before on TED Talks as well, which is great to see that out there, and it's very impressive what she's done. I'm excited to see what she's doing in Canada and seeing how that's. And unfortunately, she's already tried to recruit Dan over to Canada just prior to this talk. So careful how much you listen to her recruitment processes. But Richa, if you could share your slides, I will disappear as soon as we can see them. You're just on mute as well.
Is that there showing up?
They're not in presenter view or
Okay.
slideshow mode yet, but
There we go. I think it's loading.
there you go. Yeah.
Okay. Thank you so much. This has been very good learning for me as well. So I am actually I did study medicine in the UK at the University of Leicester, and then went on to do my pediatric residency in Canada, and then certified through the American Board of Lifestyle Medicine. So it's actually really great to be here and speaking with a British audience, and I'd love to learn more about how we can kind of collaborate and improve the health of children for generations to come through the lifestyle lens. So I am a community pediatrician, and I am the clinical director and co-founder for an innovative mental health pediatric lifestyle medicine clinic called the Pediatric Health and Wellbeing Clinic. It's in partnership with our local mental health hub, which is also an NGO. So we're really trying to improve access to care in our underserved area here. And we use the pediatric well-being curriculum and the practical framework in the groups that we provide in our shared medical appointments, and also in our individual care clinical appointments as well. So if you want more information, you can actually check that website out, pediatricwellbeingprogram.ca. So I wanted to start with a case, as we are often encountering cases. This is a fairly typical case that we see in our clinic. So 5-year-old male with school difficulty, behavior problems. The question is, does he have ADHD? The school reports that he's acting out. He's screaming when he's told no. Occasionally he's hit a child. His academic performance has been declining. He's easily distracted, and he's often found staring off into space. When he's expected to be seated, he's getting up, and he's been disruptive to his class. So I want you to keep this case in mind as we go through the presentation. So to illustrate the overarching value in the practice of lifestyle medicine and how it can integrate really well into pediatrics, I wanted to touch on the fact that guidelines in the management of various non-communicable conditions and chronic conditions, such as type 2 diabetes and even mental health disorders like depression, will often recommend lifestyle modification as a first line, but in our training we don't get often much in-depth background on how to assist patients and their parents in making these meaningful, sustainable changes. So that's where the practice of the lifestyle medicine, in terms of education, it looks like the resources from Lifestyle First are also very much aligned and can be utilized in partnership as well. So when speaking with children and families, we can actually utilize motivational interviewing to increase their intrinsic motivation toward building their healthy habits. And through motivational interviewing, we can help patients and their parents identify and resolve inner conflicts, build confidence, and move toward their goals. So it's also useful to helping people overcome ambivalence, particularly those who are in the pre-contemplation or contemplation stages in the trans-theoretical model of behavior change. So the incidence of non-communicable conditions previously seen in adults only is increasing in the pediatric population, and this is particularly significant because the earlier in life a child develops a disease, the longer they live with the morbidity associated with that disease, with the potential for developing more severe diseases and complications. In fact, it's been demonstrated that obese children and youth have a higher lifetime risk for developing diabetes, dyslipidemia, hypertension, coronary heart disease, but there's also an increased association with mental health disorders. And on the bright side, childhood and adolescence pose a critical opportunity for prevention and early intervention. In fact, studies show that when those adolescents with higher BMI reduce their BMIs before adulthood toward healthy targets, their risk factors for cardiovascular disease dropped to that of the general adult population. And changing habits in adolescence was shown to be easier than in adulthood. making pediatrics a prime area in which lifestyle medicine can be implemented from a prevention standpoint. Now, in summary, the pediatrics offers an opportunity for prevention and various opportunities. In Canada, the pediatric timeline or lifespan is 0 to 18 years, and it offers an opportunity for prevention while children are building habits for the very first time, and parents can make informed decisions toward building healthy habits. It's also an opportunity for early diagnosis and intervention with greater potential for disease reversal and halting the disease progression, all while providing opportunities to enhance well-being and resilience, potentially improving the child's experience of their childhood. And there are also some potential beneficial side effects. For example, improving parent health and well-being, because they are the ones that are making the decisions in the home. And then there are opportunities for population level, longer term impact, one child and family at a time. So quickly to review those 6 pillars of lifestyle medicine, they are all interconnected and each one affects each of the others directly or indirectly to impact the overall health of children. I will usually ask about these pillars as part of my review of systems in all of my consultations, and sometimes it's sort of sprinkled out throughout the consultation. Now, we use growth charts as one of our objective measures in pediatric care, plotting the height, weight, head circumference, BMI on a standardized curve, and its age and sex matched for the population. This is just a Canadian example, but I know you guys have your own version. So while this gives us general information, it can be helpful to assist in certain diagnoses and, for example, failure to thrive or endocrinologic versus alternative etiology. What the growth curve does not show us is the quality of the child's diet. For instance, if there's a clear difference between following a normal growth velocity while eating mainly ultra-processed foods and following a normal growth velocity while eating whole food, plant predominant diet, we really cannot see that difference when they are plotting equally. Now, we could talk at length about the various nutrients, but to illustrate my point, I want to focus on ultra-processed foods. Ultra-processed foods make up a majority of children's diets worldwide, and if we don't ask, we don't know what our patients are eating. So in a UK study published in the European Journal of Nutrition, toddlers obtained 47% of their calories from ultra-processed foods, which rose to 59% by the age of 7. Caloric intake from ultra-processed foods was also shown to increase in youth in the US. So if a majority of the food that children are getting are from ultra-processed foods, this can pose significant issues down the line, particularly because ultra-processed foods are high, I'm preaching to the choir here, are high in sugar, saturated fats, and salt or sodium, and they are nutrient poor. So they're calorie dense, nutrient poor, and are associated with a lot of those chronic diseases that we are seeing rise in the pediatric population. So the quality of food matters. And nutrition has a significant impact on child growth and development. It influences the developing microbiome and has an epigenetic influence. That is where some disease-causing genes are turned on or off. In fact, studies have long shown that diets high in saturated fats, processed foods, and sugar are associated with adverse health outcomes, including diabetes and cardiovascular disease. But what about mental health? Diets higher in fruit and veg were associated with better mood. And developmentally, diets higher in saturated fat or sugar and processed foods are associated with lower IQ and poorer cognitive performance, while more nutritious foods like fruit, veg, whole foods are associated with higher IQ and improved cognitive performance. And similar trends are seen in the youngest populations when Mediterranean diets are followed in pregnancy. This was associated with a higher IQ in offspring in toddlerhood. So the general consensus based on the data is fairly clear, and there is consistent messaging. We can use Canada's Food Guide as a great example. It's a great resource for healthcare providers and families. In general, the consensus is increase your intakes of vegetables, fruits, legumes, nuts, seeds, whole grains, and saturated fats, and reduce or minimize the intake of processed meats, sugar-sweetened beverages, and saturated fat. So I like to keep a 24-hour diary for my patients. I usually ask, what's a typical breakfast, lunch, dinner, snacks? It sort of creates a foundation or a baseline or a springboard upon which further counseling can then be made and nutrition prescriptions can be made. So we can utilize SMART goals. And in general, people do better with addition of food than removing food, and also with swaps. And so now we'll move on to sleep. So sleep is important for rest, restoration, memory consolidation, but it's not just about adequate duration. The timing, quality, regularity, and absence is also very important. So it's important to know the different ages and the ranges that are appropriate for sleep. And we know that in between the ages of 3 to 5, children are usually dropping their naps. And so if anybody's napping between 6 to 18 years of age, it should raise alarm bells that we probably need a medical assessment there as well. Now, particularly in pediatrics, sleep is important because children are growing, and it's important for neurodevelopment, physical growth, and overall well-being. It's important to know the normal sleep patterns, and sleep disruption and disorders can influence both physical and mental health of children and adolescents. It can be part of the clinical picture and the reason for the referral, for example, in our case, or they can be presenting with an illness or symptom and have a comorbid sleep disorder that may be contributing. For example, in the case of obesity, there's a reciprocal relationship between obesity and poor sleep quality as well as short sleep duration. Both these factors can predispose to weight gain. Meanwhile, obesity in childhood results in poor sleep and higher prevalence of sleep disorders such as OSA. And children with ADHD may also have higher incidence of comorbid sleep disorders such as restless leg syndromes. So there are multiple health consequences of sleep deprivation, and looking at these consequences, you can see that they would be a relevant part of an ADHD history. So with regards to mental health, there may be mood disorders, depression, struggles with emotions. There may be emotion regulation and self-regulation problems as well. And there are multiple benefits of improved sleep, particularly as sleep disruption and sleep disorder in the younger ages may increase the risk of developing mental health disorders later in life. It's a really important aspect of the pediatric history from a preventative health standpoint. This is the BEARS screening protocol that you can use to take a sleep history and identify underlying sleep disorders. I'll usually take a sleep history that includes what is their bedtime routine, looking for the 3 Bs, brush, bath, and book, bedtime, what time is bedtime, how long does it take for sleep initiation. Ideally, you want 20 to 30 minutes, whether they stay asleep or awaken through the night, whether there's any snoring or apnea, what time they wake up, and are they sleepy or rested, and whether there's any daytime somnolence. And this is an example sleep diary. So I tend to ask families to record sleep over a 1 to 2 week period. I find that this helps them understand that sleep actually happens as part of a 24-hour cycle, and what you do in the day affects night and vice versa. And then I can provide specific tips and perhaps even diagnose sleep disorders that may be contributing to my patient's presentation. For example, OSA can result in behavioral challenges. Iron deficiency anemia can result in sleep challenges and also in behavioral challenges. And the poor sleep can then contribute further to the behavior and learning challenges. Now, here's a quick note on caffeine. We already heard Dan talk about it earlier. So just noting that, especially in teens, we want to ask about all sources of caffeine, pop, coffee, tea, energy drinks, and there is a daily maximum. And also important to emphasize that it's not had later in the day, so sort of past 12 to 2 p.m., because it can impact sleep. Educating patients on sleep physiology can also be helpful, particularly on aspects of their daily lifestyles that are affecting their sleep and vice versa. I talk about the sleep-wake cycle, the circadian rhythm, and melatonin, which I've found has helped patients understand why certain recommendations are being made. So with regards to melatonin, I discussed the role that it's a naturally secreted hormone in the pineal gland. It's involved in sleep. It influences our sleep-wake cycle. It's affected by light and dark and changes in temperature, and it can change our sleep onset and duration, and that we can influence it by our daily choices, movement, food, time outside, travel, and screens. I also tend to draw this curve. It's a very simplified melatonin curve to share with my patients, showing that melatonin drops in response to daylight, increases in response to night or darkness. And this helps children and parents understand the reasons why we make certain recommendations around sleep. For example, why they should avoid screens for 60 to 90 minutes prior to bedtime, because that's how long melatonin is suppressed after exposure. And then we create SMART goals, and it's important to kind of be mindful that every little bit goes a long way. So SMART goals are kind of my starting point when it comes to sleep. And general hygiene, sleep hygiene tips are thinking individual on the individual level, be consistent. Bedtime and wake up time are consistent every day of the week. So within half an hour on a weekday, within an hour on a weekend. Do something boring in bed, so book or boring activities. And then you're thinking about outside of the individual level, what is the bed for? The bed is for sleep. If they're not asleep within 15 minutes, they need to get up, do something really calming in dim light and really boring. And then what about the bedroom? Well, the bedroom environment also makes a difference. Both in the daytime and at night, you want to make sure they're not doing stressful activities like homework if that stresses them out, or there's not arguments happening in the daytime. And at night, it's a cool, dark, and quiet space. Sometimes background noise like a fan can be helpful as well. Avoid bright lights and screens. So we talked about the screen use, but also the other aspect is if they wake up in the middle of the night, it's important to be mindful that they should not turn any lights on, because that can advance their clock and then they'll wake up earlier than their body feels rested enough to. Avoid naps, especially past 3 p.m. or so the afternoon. Avoid caffeine at least 4 to 6 hours before bed, and avoid exercise 4 hours prior to bedtime. Now, physical activity is essentially movement. It's important for us all to keep moving. And in children, especially younger ones, it's done in an unstructured way through play. So we encourage and advocate for opportunities for play at school and at home. And this may look like actively scheduling in play dates, time for play, extracurricular sports, and physical activity, which will effectively prevent default sedentary behavior such as screen use. Now, there are numerous benefits to physical activity, and it is just as important to encourage people to keep moving as it is to encourage them against sedentary behavior. In fact, sedentary behavior is an independent risk factor for chronic disease. And so in Canada's movement, we have a 24-hour movement guideline. And I did check that the NHS is aligned with our 24-hour movement guidelines. It's entirely evidence-based, so that's unsurprising. But for years 1 to 4 of age, 180 minutes of physical activity at any intensity is recommended. And in Canada's movement guideline, they also recommend against sedentary behavior in this age group, which includes not sitting for more than an hour, no screens under the age of 2, and screen time less than an hour over the age of 2 when you're between 1 to 4 years of age. And when you're sedentary, they encourage reading and connection building activities. So the quality of the time spent is also emphasized in that guideline. So in the 24-hour movement guidelines, between 5 to 17 years of age, they recommend 60 minutes of moderate to vigorous aerobic physical activity daily, as well as 3 days a week of muscle strengthening activities and bone strengthening activities. And those include skipping, hopping, jumping, playing in the playground, gymnastic, climbing, tennis. And here's a snapshot of the evidence-based recommendations for 5 to 17-year-olds in the 24-hour movement guidelines. And I share this to demonstrate that it includes sleep and sedentary behavior, as they all impact physical activity and general health outcomes. And just to note, the website also has evidence-based resources from birth to 65 and up, which I believe is a great resource showing the interconnectedness of the pillars of lifestyle medicine. So how do we help families understand what's moderate and vigorous? Moderate is when you're breathing faster, you can carry on a conversation, but you're no longer able to sing. And vigorous is when you are gasping for breath and you can't sing or talk. And then again, we create SMART goals. And so there are different levels of stress when it comes to the stress management pillar, but here we're going to, because you can have positive stress, which is important, but we're going to focus on the pathological stress. So stress in pediatrics is also related to parental stress, which is currently at a high level worldwide. Parental stress can impact childhood stress levels as children co-regulate in the presence of their caregivers, and thus it can influence their overall health and well-being in the longer term. So I'm particularly referring to adverse childhood experiences here. So in my practice, outside of focusing on what stressful triggers are and what are some general stress management strategies, I found it more useful to ask very specific questions like, what fills your child's cup? What do they enjoy doing? What are they good at? What helps them manage their stress when they're feeling heightened? And asking the parents how they co-regulate their emotions with them. How do they co-regulate? And how do they regulate their own emotions when it comes to their own stress, because they are modeling that behavior with their children? And what role does music and nature play in their lives? Because that way you can cater your SMART goals accordingly, so you're co-creating them. So there are various evidence-based ways to manage stress, but there's no one size fits all, and it's important to provide counseling in line with patient values. And in the mental health work that I do, I often provide CBT and coaching to both children and parents when it's relevant. But generally, parental well-being, especially in the early years, has been shown to directly impact that of their children as well. So we really want to encourage families to do more of what they enjoy, whether it's walking in nature together, deep breathing, box breathing. I'll even demonstrate it in my clinic, and then we kind of have the patients do it along with me, and we can show them in real time how it actually brings their stress down. Progressive muscle relaxation, grounding, mindfulness, gratitude journal, and music. So again, we create SMART goals. So social connectedness is an internal sense of connection and belonging, and this likely looks very different for every individual. Someone may feel more connected in a choir and another more in one-to-one play, but it's built in different ways as well. So small steps at a time. So the benefits of social connection are numerous. It increases longevity, lowers rates of anxiety and depression, higher self-esteem and empathy, better emotion regulation, improved overall well-being, and stronger immunity-related gene expression. And the dangers include being worse for health than smoking, hypertension, or obesity, higher inflammation, higher susceptibility to anxiety and depression, slower recovery from disease, increased antisocial behavior and violence, and suicide. Parents are the first social connections that children actually make, and family meals are beneficial for parents and children alike. So it's actually recommended that families have meals at least 3 to 4 times a week together. It's associated with better mental and physical health, higher self-esteem, better academic performance, better nutrition, and learning about a variety of foods. And this is something in pediatrics we actually have a very unique opportunity to be a part of, where we can encourage people to eat regularly at every child visit. You can actually talk about your rose, thorn, and bud at dinner, for example. And also, when kids are starting solids for the first time, we're talking about eating meals together. Parents can model how to eat. Children can learn basically how to eat by watching their parents, but also how to feel about the food. So the way that parents model enjoying the food, also model eating mindfully. Parents can model delighting in vegetables and build a healthy relationship with food. So it's also an important opportunity to build a child's relationship with the parent as well. And it's an important time to emphasize that screens should not be used at the table or even in the background, because it can disrupt that connection, but also it encourages mindful eating or intuitive eating, where kids are in tune with their hunger and fullness cues when there are no screens present. And we can actually nurture relationships in different ways, and this can look different for everybody. So acts of service, kindness, and generosity, because compassion creates connection. If you need help, ask for it. It actually creates a sense of belonging for the one who's being asked. Look after yourself, set boundaries, because stress actually reduces connection. And then play dates. It's important to remember that for every child that looks different. So from a mental health standpoint or with neurodivergence, there may be a preference for one-to-one rather than groups, or perhaps playing with certain individuals they feel safest with. So it's important to pay attention to that when considering prescriptions for play. And remember that happiness is contagious up to 3 degrees of separation. You can also start a Walk with a Doc chapter. I've recently started one in my community. It's an event led by a local healthcare provider. It's open to people of all ages and ability. It allows the participants to safely take a walk, learn about a health topic, and meet new people. So a few of us actually bring our children. It's a built-in play date, and we're modeling the importance of getting outside, even on the coldest day of the year. There are numerous benefits. For example, being in nature, which brings down stress levels. It can improve sleep. It's an opportunity for mindfulness practice, connection, including the powerful effects of entrainment, where our heart rates and our respiratory rates can align with one another, learning, physical activity, and it is a scheduled alternative to screen time. And lastly, is the risky substances pillar. And in our pediatric well-being program, we focus on risky behaviors more generally, and therefore we include screen use under our adapted pillar of risky behaviors. There are 5 preventative and early intervention aspects we consider in our program. One is the parent's behavior, because that can impact the child, directly and indirectly, and this changes along the pediatric lifespan. For example, alcohol use disorder and secondhand smoke both impact developing children and can increase the risk of SIDS in newborns. The risk of exposure is number 2. So for example, accidental ingestions. But when we're thinking about screens, it's the potential for exposure to harmful, developmentally inappropriate content, and even if chats are available, really harmful individuals that can access children through screens. Number 3, the impact on the parent-child relationship. So screens are a form of technoference or phubbing, where someone's ignoring the person in front of them for their phone or technology. And this has negative impacts on both the child and the parent's mental health. And then modeling. Children learn from watching their parents, and the way that they're using technology is important because that's how children are going to likely use the technology. So we create family media plans. There's a great resource on the American Academy of Pediatrics website called the Family Media Plan. And we're just finding ways to help guide families to use screens in a mindful way that's aligned with their values. Moreover, studies show that adolescents are more likely to start and continue smoking if their parents did so. Now, when there's a child or a teen engaging in a risky behavior or like problematic screen use or drug, alcohol, or tobacco use, we would usually identify and counsel through motivational interviewing, SMART goals, as well as personalized plans and making appropriate referrals and medication starts as relevant. And on a special note, with regards to alcohol and tobacco, we know that these are group 1 carcinogens, and it's important for families to be informed so that they can make decisions aligned with their own values, resources, and barriers. And this is really important from a preventative standpoint in pediatrics because kids are learning from the community at large as well. Now, here's a tip when thinking about smoking. If a child comes in with an asthma exacerbations and parents smoke, which is a known trigger, a discussion around quitting can be had, and this can be a cue to action to encourage behavior change for parents. So overall, we can use lifestyle medicine at pretty much any type of pediatric visit. At well-child visits, we can address the 6 pillars. You can go one at a time. You can focus on the pillar that the parent wants to focus on. You can use questionnaires, motivational interviewing, parent coaching, psychoeducation, and set SMART goals. When it comes to screening and assessments, monitoring those with risk factors for chronic disease. For example, if mother had gestational diabetes, they are of a particular ethnicity associated with higher risk of diabetes, and the child has an elevated BMI, this can increase the risk of their developing type 2 diabetes, and other comorbid conditions are important to screen for. So you should be screening for regular blood pressure, glucose, HbA1c, and lipid panel, for example. Poor sleep can increase the risk of mental health disorders later on in life and also can result in weight gain. So again, a really important pillar to be focusing on. And screening also allows for identification and timely intervention. And then when we have children referred for particular pediatric referrals, each of the 6 pillars can be incorporated as they can impact the presenting complaint, as we will go through in our case associated with the question of ADHD. Remember our 5-year-old male from the beginning. So if we apply the 6 pillars, and I didn't actually put in the social and what was the other one? Social connectedness and stress management pillars here, because that would end up being a very long talk. But the nutrition pillar, so what really stands out here is there's a lot of dairy. So more than 2 to 3 cups equivalent of dairy increases your risk of iron deficiency anemia, and that can actually impact sleep, but also can have many of the symptoms associated with ADHD. There's a lot of ultra-processed foods, excess sugar, chocolate milk is a sugar-sweetened beverage. Great, they have carrots, yeah, for the win. Physical activity looks okay. Their sleep is inappropriate, so about 5 to 6 hours when a child should be getting 10 to 13 hours at that age. So that really is an important one to focus on. And if we never ask about it, we don't actually know that that is a it's half the amount of sleep that child should be receiving, and we can't optimize that. And if we want to start stimulants, it's probably going to affect sleep even more. So it's also important from the management standpoint when we're looking into the future to know about their baseline sleep. And then screen use, we can see here that there's quite a lot of screen use for this child, 3 hours. And so overall, when we look at all of these pillars and apply it to ADHD generally, and in this case, iron deficiency anemia can present similarly. It can exacerbate your symptoms, and it can also impact sleep, so other pillars, so it's important to treat. Sleep can impact your behaviors like we've talked about. Screen use encourages sedentary behavior. It displaces one-to-one connection. And we know kids who are actually feeling more socially connected, who have ADHD, it improves their self-esteem. Physical activity is also really important for kids who have ADHD, and sometimes schools will remove recess. I'm not sure if that's happening in the UK, but they remove recess as a form of punishment. So it's important for us as pediatricians to be advocating against removal of recess as a punishment for ADHD as well. Stress management, so mindfulness, progressive muscle relaxation has all been helpful for ADHD, and social connections, as I've said. So you want to make sure that parents are also parenting according to the diagnosis, involving occupational therapy and counseling and medication as well. And that's it. So thank you. I think I just about hit the time.
Well, a couple of minutes over, but I think pretty much everyone's still here listening and thinking how fantastic it is. So thank you very much. There are a couple of questions. I know we're over time, but if you're happy just to hang on around for a couple of more minutes just to answer those questions, that would be really, really great. So
Absolutely.
Sanjay Suri asked, thank you. Any views on later school start times for adolescents due to their circadian rhythms?
Yes, I think that's a really great point, and I'm with you on that. I think there are ways to advocate, and I wonder if there's maybe some alignment with the Lifestyle First and Daniel's team, because um, it really, if you can kind of maybe BSLM can come together as pediatricians, and the school team can come together to really advocate for later school start times, because there's a lot of evidence that it's really important to optimize sleep. And we know that kids are getting insufficient sleep toward the end of the week, and then they're catching up on the weekends, and then you're catching your tail on Monday morning. So there are some groups that have advocated, and I believe there's a group in Montreal and Quebec that's advocating. There are some resources online through the AAP. We don't have any through the CPS, the Canadian Pediatric Society, yet, but I totally agree. If there's any way that you want us to collaborate, I am all for it. Writing op-eds is a great way to advocate. If you can pool together people who are in this sort of space, it can really be helpful as well.
Dan, your camera came on immediately. Did you have something to add to that?
And no, I was just going to agree completely. I think, and I think especially I feel during the winter months, the need for sleep is greater, I think, in that kind of November to February time. And if we just gave an extra hour in the morning to staff and to students at secondary schools, I think everyone would be winning. People are, the teachers, the students are just, they're just so tired. So how much learning and how much great teaching goes on in that time, I'm not sure. You give them a bonus of an extra hour in bed, I think you'd find everyone's in a much better mood.
As long as we do it for doctors as well, then I'm on board. That sounds great. The next question is from Monica Gupta. I agree with everything you've mentioned and the SMART goals, but how do you introduce this within the NHS in a 15 to 20-minute consultation? At the moment, this is only possible in a 1 hour specific coaching consultation privately.
Okay. And yeah, time is always the issue. I think one of the ways to think about incorporating it into the sort of the shorter time frames is if you're coming in for a single complaint, for example, maybe going through the pillars with the family and sort of saying what's maybe you could even have a checklist on your intake form or something like that, like which pillar would you like to focus on today, and list all the 6 pillars, and then make a SMART goal around that. But I see, it is really hard with the shorter clinical appointments. And it's something I think about often, because if we can, that's really the access issue, right? If we can get more pediatricians able, or family doctors able to ask these questions in their routine visits, then we would look, the population's health would look a lot different. So I think one of the things I think about is one pillar at a time. And sometimes it should be a collaborative effort. And maybe at the end of the appointment, you just raise to the patient before they leave, which pillar would you like to focus on next time, and maybe spend the next couple of months or however long it is before you follow up, thinking about how they're optimizing some of that and maybe some of the questions that arise around it. So just giving them some homework and also focusing on one pillar.
That's really practical, really helpful. I think this again could be another potential collaboration. I know the American College of Lifestyle Medicine, their adolescent mental health toolkit is sort of that homework. It has some of the tools that you referred to in your talk as well. So some sort of package of homework that you could give them that's adjusted for different ages would be really great to utilize.
Good idea.
Really helpful. One last question. This relates specifically to your case from Samantha Hardman. So would you diagnose ADHD in this scenario or wait until you have sorted some of the pillars?
I think that's a great question. And I think it's one we see very often in our mental health lifestyle medicine clinic. So it really is case dependent. So in some cases where I feel that actually the sleep is causing a significant issue, I will have them optimize the sleep first and foremost in this assessment process. And sometimes that's challenging, because we do have families that come to us in crisis and they're really looking for a very quick Band-Aid response. But in this case, especially, this child also had a lot of social issues. So that's why I didn't really go into it, but there were a lot of ACEs, so a lot of adverse childhood experiences. So if the parents are going to have a hard time actually instituting what needs to be done to help the skills, the way I counsel is the medication is like, the resource, my brain needs glasses. The medication is like glasses if you needed glasses, but it's not going to teach the child the skills. So they still need to be able to do both, and we need to help optimize the sleep anyway. So let's see how he does once you've optimized that sleep, and then we'll follow up in another, couple of weeks, a month. We'll see. I can often follow these cases fairly closely as well, because we have the capacity with our groups to do so, but you can follow on a weekly basis and just check in. How's the sleep going? And then focus on another pillar at another time that might be contributing. So let's do some blood work. Okay, it's the iron. Let's optimize that iron. If you feel the iron deficiency is not quite so significant that it can't possibly be contributing to such a behavioral shift, also how acute was that behavioral shift. So absolutely, I think on a case-by-case basis, I would be looking at all of these pillars and optimizing what I think is contributing within that diagnostic process as well.
Fantastic. I think those are all the questions that we've had. Lots of comments coming in about how fantastic both speakers were. So thank you both so much for joining us today. If you haven't filled in the questionnaire, the survey, for those who have attended, please do fill it in. If there's anything else you'd like us to organise or speak about in the future, we would love to hear about it. But on behalf of everyone at BSLM, thank you so much for joining us today, and thank you for such a fantastic talk. So thank you.
Thank you for having me, and it was great to meet you all.